I think though the subject that was given to me was an easier one. I don't have to prove something that is very difficult. So before we talk about access sheet or no access sheet, I would like to tell you that we are using something to facilitate ureteroscopy. We know ureteroscopy has diagnostic and therapeutic uses. Most obviously, the urethiasis for more than 90% of the indications. Now, since the access sheet that Mitch has mentioned that in the mid-1970s, we haven't seen anything about access sheet. And part of that is until Clayman came with his access sheet in the late 90s, part of that due to the excellent refinement of the ureteroscopes. And Mitch, you've showed us why do we use access sheet. Those are all theoretical things. Are they really 100% sure? So these are the pre-ureteral access sheet conditions. So we have dealt with improvement of the semi-rigid and the flexible scopes. We have managed to get less than 5 French and flexible scopes that were available to manage all the failures of the shockwave. Subsequently, the introduction of holmium laser by John Densett have revolutionized stone treatment. Accessing the lower pole, repositioning the stones, all those things have shown that you can get an excellent results. What was reached so far before we use access sheet, that we have low infection rate, low structure rate, efficiency, we are dealing with excellent stone-free rate. The problem was the quality of life when you see the literature, and most of those were related to stent. Now, what are the problems with stenting? That you have major lower urinary tract symptoms, mostly irritative symptom, dysuria. We also have the cost of putting a stent and removing a stent, and the possibility of infection, leaving a foreign body there. Until the group of, from Western came with a prospective randomized study that shows that stenting or no stenting has no impact on the stone-free rate or the patient's outcome, except that there is less bothersome symptoms. Subsequent to that study, enormous amount of randomized control studies, and even the largest was a meta-analysis by Wang and his colleague that showed 22 randomized control trials, and it has showed that in fact there was lower stone-free rate in the stented group with increased complication, mostly dysuria and hematuria. And you know what, Dr. Humphrey, interestingly, there was no difference in the immediate or post-operative pain, stricture, or hospital stay. Regarding the stone-free status, still we have a problem defining what is a stone-free status. Is it 1, 2, 3, or what is labeled sometimes in the literature the clinically insignificant fragment? We know from review of the literature, even diagnosing a residual fragment is a problem. Is it CT scan? Is it ultrasound? I still don't know what we should use. Sometimes we use for medical dissolution therapy for cystinuria or uric acid stone. In our community, we have larger number than North American with uric acid stone. So, sorry about my spelling mistake, again, one of my problem from, so theoretically, the ureteral access sheet should have a better stone-free rate. Is that true? The same guy you quoted his paper, Olivier Traxler, showed that the prospective clinical trial, there was no difference in a stone-free rate. In another group, in another paper by the same group, DeConnick and his colleague in a systemic review showed that inconclusive evidence that the stone-free rate is less, infection or pain or stricture. So we are not having level 1 or 2 evidence of what you hypothesized earlier. So what is the problem now? So I'm dealing with access sheet increased cost, DJ stent, and the cost of increased stent removal. So where are we now? This is a problem about the potential of improving flow and decrease infection. This is by Huang and his colleague in February of 2018, enormous number of patients, about more than 3,000 procedures. And what was the result? Again, no significant difference in either stone-free rate or intraoperative complication, operative time, or hospitalization. And you know what was more striking? That there was more post-operative complication with the ureteral access sheath. So what the access sheath doesn't add to my practice, it doesn't add extra safety, more stone-free rate, less cost, or less morbidity, or better quality of life. So why would I change? So Dr. Humphrey, until you show me a stronger evidence, I will not continue to use access sheath. I will try to save money. I will be more caring about my patients, since when you do use access sheath, you will use a stent with the complication of stent. I will try to stay away from that picture, though you said it's only very minimal amount of patient, but you can beat me and scar my face, but I will heal at the end, but still I don't want that effect. Thank you very much.